My name is Dr. Mohit Khare. I am assistant professor in the Department of Cardiology at UNMICRC Institute of Cardiology and Research Center. Today, I will be speaking on the topic of renal artery stenting. So, this is how we are going to proceed. We will be first looking at renal artery stenosis, epidemiology, and natural history. Then we will be talking about clinical manifestations of renal vascular disease, how to image and assess the functional severity of atherosclerotic renal artery stenosis. Then we will be looking into the clinical indications for renal artery stenting. Further, we will be discussing about the renal revascularization techniques, and lastly, we will be discussing the contemporary trials, what their results were, and then we will see a summary. So, most of the cases, almost 90% of the cases of renal artery stenosis are due to atherosclerotic narrowing. The remaining 10% of cases are accounted for by fibromuscular dysplasia, which is a cause of hypertension in young females, then trauma, dissection, external compression, renal artery aneurysm, vasculitis, retroperitoneal fibrosis, radiation-induced stenosis, etc. Now, atherosclerotic renal artery stenosis is the most common cause of secondary hypertension, accounting for 2 to 5% of cases. And it has a particularly strong association with malignant hypertension, accounting for nearly 45 to 50% of cases presenting with malignant hypertension, that is hypertension with evidence of end organ damage. The prevalence of renal artery stenosis increases with age, also in those who have comorbidities like diabetes mellitus, hypertension, coronary artery disease, and peripheral arterial disease. So, like any other atherosclerotic vascular disease, the risk factors are common. This is further clarified in a Mayo Clinic series, wherein it was found that around 20% of patients who had coronary artery disease and hypertension, they were found to have more than 50% stenosis of the renal arteries. In another prospective study of around 76 patients with at least one abnormal renal artery, it was found that the progression of renal artery stenosis from those who had less than 60% stenosis at baseline to more than 60% was 30% at 1 year, 44% patients progressed at 2 years, and this figure increased to 48% by 3 years. But unfortunately, it is difficult to identify which subset of patients would progress and will eventually have hemodynamically significant stenosis. So, what are the clinical manifestations of renal vascular disease? The first and foremost, it is hypertension. Now, in patients who have unilateral renal artery stenosis, there is activation of renin-angiotensin pathway, and these patients have what is known as renin-mediated or renin-dependent hypertensive state. So, because of the action of aldosterone and angiotensin 2, there is increased sodium and water resorption, there is constriction of the efferent arterioles in the affected kidney, and this is compensated via hyperfiltration by the contralateral kidney. Whereas in patients who have bilateral renal artery stenosis or who have renal artery stenosis in a solitary kidney, there is volume expansion. The kind of hypertension they have is volume overload mediated hypertension. Here, as a result of volume expansion, there is renin suppression. And these patients, that is those who have resistant hypertension with bilateral or solitary kidney severe renal artery stenosis, these are considered appropriate candidates for renal artery revascularization. But so far, patient subset identification has been controversial because it is possible that these patients may have a background of essential hypertension over which renovascular hypertension is being superimposed. The second clinical manifestation of renal vascular disease is cardiac destabilization syndromes. So many times patients who have severe bilateral renal artery stenosis present for the first time with flash pulmonary edema, or they may present with history of recurrent congestive heart failure. They may even present with acute coronary syndrome. So any patient who presents with these manifestations in the setting of uncontrolled hypertension should be evaluated for renal artery stenosis. The third manifestation of renal artery stenosis is ischemic nephropathy. As a result of decreased blood supply to the affected kidney, there is loss of glomerular surface and extensive fibrosis of parenchyma over time, which leads to shrinking of the kidney size and decline in renal function. Now, patients who have advanced nephropathy are not likely to benefit from revascularization, and through studies it has been found that patients who have proteinuria more than 1 gram per day kidney pole to pole length less than 7 centimeter, or have been on hemodialysis for more than 3 months, they have sufficiently damaged kidneys and are not likely to benefit from renal artery stenting. Now, in a study, it was found that almost 12% of patients who have end-stage renal disease have CKD attributable to progressive ischemic nephropathy from renal artery stenosis. Hence, any patient presenting with CKD, a new onset CKD, must be evaluated for this condition. So, how do we assess the renal artery stenosis, both anatomically and physiologically? The initial choice for diagnosis of renal artery stenosis is renal Doppler ultrasound imaging or duplex imaging. It can produce images of the renal arteries, it can assess blood flow velocity and pressure waveforms, it can measure kidney size, and the advantage is that there is no contrast or radiation exposure to the patient. A peak systolic velocity of more than 200 centimeter per second is 95% sensitive and 90% specific for more than 50% stenosis. Now, this is shown in the image on the right side of the slide, where we can see the blood flow in the kidneys, and the peak systolic velocity is being measured in the baseline in the bottom part of the image. Another parameter that can be measured via duplex imaging is ratio of renal artery to aortic velocity, the RAR. This is also used to estimate percent diameter stenosis. We'll see how. The limitation of renal Doppler imaging is that it is operator dependent. It depends on the expertise of the operator. Patient obesity and bowel gas can obscure images, and hence in obese patients it may not be a very useful investigation. So, as per the American College of Cardiology AHA peripheral arterial guidelines, the degree of stenosis can be quantified based on the duplex criteria. That is, up to 59% stenosis, duplex criteria is renal artery ratio less than 3.5 and a renal artery peak systolic velocity is less than 200 centimeter per second. Those who have stenosis 60 to 99%, their renal artery ratio is, renal aortic ratio is more than 3.5, or a PSV is more than 200 centimeter per second, along with evidence of flow turbulence. And those who have occluded renal artery, there will be absence of arterial flow and there will be a low amplitude signal. So, in those patients in whom duplex imaging is non-diagnostic, or those patients who are being considered for invasive angiography but have unfavorable anatomy, MR or CT angiography is a useful investigation. So, advantage is that apart from imaging the renal arteries, it also allows additional visualization of the aorta, any accessory renal arteries, and renal parenchymal anatomy. The limitation with CT angiography is that it requires iodinated contrast, and hence there is a risk of contrast-induced nephropathy. With MR angiography, there is a risk of nephrogenic systemic fibrosis due to gadolinium contrast. If we look at the sensitivity and specificity for CT angio, it is 90% and 97% respectively, while that for MR angio, it is 97% and 93% respectively. So, patients who have heavily calcified arteries, MR angiography is preferred, as it will give an artifact on CT angiography. However, stented vessels cannot be adequately assessed by MR angio, and CT angio can be preferred in those cases. So, this was the anatomic assessment of the renal artery stenosis. For functional assessment, we have radionuclide imaging. Here, it's also known as technetium-99 DTPA scan. Radioactive radionuclide tracer is injected in the patient's body, and a detector gamma camera is used to assess the baseline renal flow. So, a baseline flow is measured, and then after administering ACE inhibitor captopril, repeat scans are performed, which will show a decrement in the renal function or renal flow on the ipsilateral side of renal artery stenosis. The sensitivity and specificity are 90 and 93% respectively. So, this form of imaging allows to assess cortical function of the ipsilateral kidney as well as the contralateral kidney, particularly useful in the setting of those patients who have renal atrophy and renal artery stenosis. Some other tests which can be used for functional assessment of renal stenosis, artery stenosis severity, are plasma renin activity or plasma renin assay. It is used as a screening test for renovascular hypertension. Now, it has a low specificity in the diagnosis of renal artery stenosis. We saw that volume expansion actually suppresses renin production, and hence it will not be a very specific test to diagnose renal artery stenosis. In few studies, it has been found that BNP levels can be also used to assess the severity of renal stenosis. So it was found in a study that significant BP response to renal stenting was seen in patients who had elevated BNP levels at baseline. However, confirmatory studies are needed to know the usefulness of this test. Invasive stenosis assessment, for that DSA can be done, but what is to be noticed is that it has a relatively poor discrimination of lesion severity in those patients who have tortuous vessels or overlapping vessels. Now, by consensus, it is agreed that more than 70% diameter stenosis is considered severe. Those who have angiographic stenosis of 50 to 70% are considered to have moderately severe stenosis, and this is the category of patients who require further assessment of the functional severity of stenosis. So for that, we need either of these three parameters: a resting or hyperemic translesional systolic gradient of 20 millimeters of mercury or more, a resting or hyperemic mean translesional gradient of 10 millimeters of mercury or more, or a renal FFR of less than equal to 0.8. So how do we identify patients and those patients who are likely to benefit from renal artery revascularization? There are certain clinical clues where we can consider the possibility of renal artery stenosis. Any patient presenting with hypertension before the age of 30 or after the age of 55, if there is acute elevation of plasma creatinine levels or azotemia after initiation of ACE inhibitor or ARB, patients who have hypertension and are found to have asymmetric kidney size, if there is moderate to severe hypertension in patients with diffuse atherosclerosis, patients presenting with recurrent congestive heart failure or flash pulmonary edema and have hypertension, then patients who have malignant hypertension or resistant hypertension, or simply if on a clinical examination epigastric bruit is noted, these patients can be evaluated for renal artery stenosis. So as per the Society for Cardiovascular Angiography and Imaging appropriate use criteria and AHA recommendations, patients who have severe bilateral renal artery stenosis or moderately severe renal stenosis with functional assessment showing significant stenosis, in these patients, those who present with cardiac disturbance syndrome, they have class 1 recommendation for renal artery stenting. Patients who have CKD stage 4 in the same presentation are also considered for renal artery revascularization. There is a class 2A recommendation and appropriate criteria as per SCAI. And patients who have resistant hypertension with bilateral or solitary severe RAS are also considered to appropriate candidates for renal artery revascularization. So the bottom line is that patients who have asymptomatic unilateral RAS, that is patients who have normal renal function, have well-controlled hypertension, in these patients revascularization may not be required. These patients must be followed up closely for loss of pharmacologic control and accelerating hypertension, or if there is a potential decline in renal function. And these patients can be followed up using the renal duplex ultrasound imaging. So what are the techniques of renal artery stenting and what are the complications of stenting? First, renal artery balloon angioplasty was done by Andreas in Zurich, Switzerland in 1977. Currently, the acute procedural success rate are as high as 98%. The definition for procedural success varies as per the study, but less than 50% residual stenosis is by and large considered to be a procedural success. Restenosis rates were significantly lower after stent placement than after renal PTA alone, hence emphasizing the importance of placing a stent to achieve better revascularization. So the rates were 17% and 26% respectively. The goal of renal artery stenting is to achieve an optimal angiographic and hemodynamic result with minimal manipulation of the renal artery and to minimize potential atherombolization and dissection of the renal artery or aortic wall. So these patients are first pre-treated with aspirin therapy alone. In most of the cases, a retrograde approach from either common femoral artery can be used. However, those patients who have severe bilateral aortoiliac disease or tortuosity or a sharply downward angulated renal artery, that is a difficult anatomy, for those patients an antegrade approach using radial or brachial artery can be used. Now, After sheath insertion, an unfractionated heparin should be administered to obtain an ACT of at least 250 seconds. So there are a variety of guiding catheters that are available for the purpose of renal stenting. This includes renal double curve catheter, internal mammary artery catheter, hockey stick catheters. Particularly for radial or brachial artery approach, multi-purpose guide is useful. And the images of these guiding catheters are shown on the right side of the slide. So firstly, particularly in those patients in whom CT angio or MR angio has not been performed, it is advisable that before selective renal angiography, a non-selective abdominal aortography or aortic shoot should be taken to identify any anomalies in the renal arteries or any atherosclerotic disease in the aorta surrounding the renal ostium. So there are particularly two techniques for engagement of the guiding catheter to the renal ostium. The first one is no-touch technique. This technique helps to minimize distal atheroembolization. What we do in this is that we take the guiding catheter close to the renal ostium and we pass an 0.35-inch J-tip guide wire into the abdominal aorta superior to the renal arteries. This wire will prevent the scraping of the guiding catheter against the aortic wall and atheroembolization. And then the guide wire over this can be advanced through the guiding catheter into the renal arteries. Once the renal artery has been wired, this 0.35-inch J-tip guide wire can be safely removed and the guiding catheter can then be safely engaged to the renal artery ostium. Another technique is known as exchange technique. Herein what we do is that instead of using a guiding catheter, we take a 4 French soft-tipped diagnostic catheter to engage the renal ostium. The renal artery is wired using an 0.14 or an 0.18-inch guide wire, and then this diagnostic catheter can be exchanged for a 6 to 7 French guiding catheter. Alternatively, this technique can be done as a catheter-in-catheter technique. So pre-dilatation is highly recommended before placing stent with a balloon diameter slightly smaller than that of the renal reference vessel. The usual renal artery size is 5 to 6 millimeters, so slightly smaller than that. Semi-compliant balloons like Maverick Apex can be used for this purpose. What is important to note during this step is that we should look out for flank pain, because evidence of flank pain indicates there is stretching of renal artery adventitia and there is a possibility of dissection or perforation of the renal artery. So for the purpose of stenting, we have both balloon expandable as well as self-expandable stents. Now balloon expandable stents are preferred usually, particularly useful for ostial or mid-segment lesions. The stents we use commonly are Herculincolite, Express SD stent, Omnilincolite stents. What is important during stent placement is that the proximal 1 to 2 millimeters of the stent should protrude into the aorta. This will ensure proper ostial coverage of the renal artery ostium. And the advantage of balloon expandable stents over self-expandable stents is that it allows precise placement of the stent, as well as because of the balloon there is a high radial force and there is proper apposition of the stent against the renal arterial wall. Now self-expandable stents usually not preferred but can be useful in highly tortuous vessels. These stents include precise RX or Supera stent. Now these stents are more flexible, but they are not balloon mounted, they allow less precise placement. So the stent should be deployed at a nominal pressure. The aim is to achieve 1:1 ratio with the diameter of a reference vessel. Once the balloon is deflated, it is pulled slightly into the aorta, as in the proximal part of the balloon should be projecting into the aorta. It should protrude into the aorta, and then it is inflated again. This will ensure proper ostial coverage and flaring of the proximal edge of the stent. And as the balloon is deflated, the guiding catheter can be engaged with the renal artery ostium. Once dilatation is done of the stent when the stent is deployed, complete angiogram can be taken in 2 views at least to ensure there is no dissection or perforation, and DAPT is advisable for at least 30 days post procedure. So for the purpose of proper ostial stenting, there is OstealPro stent positioning system. It is a device, disposable device with opaque gold-plated feet to identify the ostium. It is shown in the right side of the slide in the image. So this device is compatible with 6, 7 and 8 French systems, and these gold-plated feet are radio opaque and they latch onto the aortic wall surrounding the renal ostium. So they serve as a marker for renal artery ostium while stenting. So it has been found that despite successful renal artery revascularization, renal function continues to deteriorate in up to 32% of patients. So, however, the usefulness of embolic protection devices has not been established to prevent atherombolism, because the argument is that it could simply be a progression of the renal disease of the patient per se, because of underlying comorbidities like hypertension or diabetes. In one study by Cooper et al., it was found that there was no decline in GFR when a combination of embolic protection device and Epidemiology was used. But there are certain risks or limitations with the use of embolic protection devices, such as renal artery spasm, dissection, lack of landing zones in early bifurcation could make it difficult to use embolic protection device, and difficulty in filter retrieval is also one potential risk. So, renal artery stenting is a fairly safe procedure. In around 2% of cases, there may be complications, particularly related to the femoral axis. This includes groin hematoma, pseudoaneurysm, arteriovenous fistula creation, infection, and retroperitoneal hemorrhage. Apart from that, atherombolization to the kidneys, bowel, or lower extremities can occur. This can lead to renal failure, ischemic bowel, or digital ischemia, respectively. There is a risk of renal artery dissection or perforation, which must always be checked once stenting is done. And if there is distal wire perforation in the renal vasculature, it may resolve spontaneously with reversal of anticoagulation, or it may require coil embolization. Rarely, it may require placement of stent graft. So, it has been found that patients in whom bare metal stents are placed, there is a 5-year primary patency rate of more than 80% and a secondary patency rate of more than 90%. The risk of in-stent restenosis, similar to coronary artery stent restenosis, there is the risk factors are common. It depends on the size of the renal vessel, usage of tobacco, poor diabetes control, and even time to restenosis evaluation. Based on various studies, the rates are different. The investigation of choice to diagnose restenosis is ultrasound imaging. It is shown in the image on the right side of the slide, which shows a patient presenting with critical stenosis of renal artery post stenting on follow-up. So there is no unified criteria to diagnose in-stent restenosis, but through various studies, different criteria have been devised based on duplex imaging to diagnose ISR. So how do we manage in-stent restenosis? There are various modalities available for that purpose. It includes repeat balloon angioplasty, stenting, brachytherapy, atherectomy, cryoplasty, and even laser debulking. But so far, no single modality has been established to be superior. There is one balloon expandable covered stent by the name of ICAST, which may help reduce neointimal proliferation to the stent struts and can be used for this purpose. So, what are the contemporary trials? What is the evidence of effectiveness of renal artery stenting? So, there have been three landmark randomized control trials in patients with renal artery stenosis to evaluate the effectiveness of renal artery stenting. The first one is the STAR trial, which was done in the year 2009 in 140 patients. So, the patients these patients had impaired renal function at baseline, and it was observed that even despite renal artery revascularization, the worsening of renal function, the primary endpoint being more than 20% decrease in creatinine clearance, there was no significant difference in the revascularization group versus medically managed group. But the limitation of this trial is that many patients had controlled blood pressure, and considerable number of patients had insignificant stenosis of the renal artery at the outset. Another trial is the Astral trial, which was done in the year 2009 in 806 patients. In this trial, patients who had atherosclerotic disease in at least one renal artery amenable to revascularization were chosen, and the improvement of renal function was noted as the slope of reciprocal of creatinine over 5 years, which was the follow-up period in these patients. So even in this trial, renal artery revascularization failed to report any significant difference in terms of major renal events, that is worsening of renal function or requiring hemodialysis, or even cardiac events. But the argument is that patients again with insignificant lesions were included in the study. Patients who had kidney size less than 6 centimeter, that is shrunken kidneys, were also included in this study. And there were no functional studies done. The diagnosis of renal artery stenosis was made with non-invasive imaging alone. And even the rate of complications with procedure were actually much higher than reported. Lastly, a recent trial, a relatively recent CORAL trial done in 2014 in 947 patients. Again, severe RAS here defined angiographically as more than 60% but less than 100% stenosis, and hypertension with systolic blood pressure more than 155 on at least 2 agents, or patients who had CKD with a GFR of less than 60 were chosen for this trial. And the time to major renal or cardiovascular event, that is stroke, heart attack, congestive heart failure, hospitalization, progressive renal insufficiency, was noted. While this trial showed a modest improvement in blood pressure, as far as other endpoints are concerned, there was no significant difference whatsoever noted in terms of major renal or cardiovascular events. Again, the arguments in this trial are that patients were not optimized on antihypertensive therapy at the beginning. Patients who had mild stenosis were also included in the study, and there was only a moderate correlation between angiography and hemodynamically significant stenosis. Hence, hemodynamic significance of stenosis must always be ascertained. So to summarize, for symptomatic atherosclerotic renal artery stenosis in patients in whom GDMT fails, that is those patients with hemodynamically significant RAS causing resistant hypertension despite GDMT, those patients who have declining renal function, and those with cardiac destabilization syndromes, these patients are reasonable candidates for renal artery stenting. Patients who have moderately severe stenosis of renal artery, that is 50 to 70% stenosis, should have the lesion's hemodynamic significance confirmed. Renal artery stenting with an optimally sized bare middle stent is the revascularization procedure of choice. And treating hemodynamically significant renal artery stenosis results in better blood pressure control and better clinical outcomes. But this hypothesis has not been proven in RCT, possibly because of limitations in trial design. Thank you.